Good morning, everybody. I am Dr. Ashish Nabar. I am the Joint Secretary of the Indian Heart Rhythm Society. The new executive committee, when it was formed in January this year, decided to extend its teaching activity for the benefit of the cardiology postgraduates and also probably early career cardiologists who are not yet decided where to branch out. And this was conceived by our president, Dr. Yash Lokhandwala, who obviously all of you know as a great teacher. And so we started doing this once a month programs on the first Sunday of every month. And we have had a good response. We would probably get more and more response as this program becomes concrete and regular feature of the IHRS activity. Today is a very special day, a Teacher's Day, and I hope you will benefit from what IHRS does best, its teaching activity for the cardiology postgraduates. This time I have requested Dr. Ajay Naik, who is a very senior electrophysiologist and the previous vice president of the Indian Heart Rhythm Society, to come forth with a formulation of a program which would be suited to the cardiology postgraduates. And he has been very kind to not only formulate a program, but also make a team who will discuss with you some common basic arrhythmia topics and maybe clarify some of the ideas. I'm sure you will benefit. I won't take much time. I will request Dr. Ajay Naik to take over and initiate this program. Ajay.
Thank you, Dr. Ashish, and happy Teachers' Day to everybody and all my teachers also. The Western India HRS group is actually a WhatsApp group. It's not a formal society. And we have a good number of EPs in Gujarat. It's grown very well. Anup has been with me for the past 20 years in Gujarat. He is senior EP at Sterling and Epic Hospital. Dr. Hiren Kevadia is my colleague and partner at SIMS Hospital. Dr. Vihang is in Baroda. He's trained with Dr. Yash Lokhandwala. Dr. Hiren has trained at Sri Chitra Institute. Dr. Neeraj Yadav was at Zydus Hospital, but unfortunately he couldn't make it today. He is busy with his father's health issues. And we have a good program today. I'd like to welcome Dr. Suchit Majumdar. You all know him. And Dr. Chandrasekharan, senior electrophysiologist from Chennai. I think we'll have a good discussion. So the program that I've drawn up, the first talk would be polymorphic VT with acquired long QT. So that should be pretty interesting. It's a very common clinical scenario that we see. Dr. Hiren will talk about it, and then I and Dr. Suchit will discuss. Everybody else is welcome to chip in. Then he'll talk about VT ablation and structural heart disease, interesting case, incorporating some of what his acquired long QT talk would be about. We encountered some pretty unusual arrhythmias in the COVID era. I'll just give a few vignettes of those cases that we saw. And finally, Dr. Vihang will be talking about ICD programming for secondary and primary prophylaxis patients, which is very relevant for everybody to understand and to practice. So it's a very clinically oriented program. I'm sure everybody will be enjoying this, and it would be very relevant for your training and your clinical practice. So without much ado, let's have Dr. Hiren. Dr. Hiren can start with polymorphic VT, acquired long QT, clinical presentation, evaluation, and management. Hiren. Hiren is young, dynamic EP. He is my partner. I'm fortunate to have him with me, and it's really been a good experience.
Yeah, thank you, sir. Good morning to all. Thank you, IHRS, and thank you to EP Group Ahmedabad for giving me this opportunity to have a talk. And thanks to all my teachers who have helped me to reach at this stage. So today, my topic is acquired long QT syndrome. Am I audible clearly?
Yes, you're audible.
Yeah, thank you. So
Hiren, just a small interruption.
Yes, sir.
We welcome Dr. Yash Lokhandwala, our IHRS president and great teacher. I'm sure will benefit from his comments through this session. Yeah, Hiren, you can please get along.
Yeah, thank you, sir. So the today's topic of discussion is acquired long QT syndrome. We'll be discussing something about the genetics, something about pathophysiology, how to evaluate what all arrhythmias they can have, and how should we manage this type of cases. So we know that how to measure QT interval. We have to make a line at the maximum slope of the T wave, and we have to find out the intersection of this T wave with the isoelectric line. So this will be the intersection. So we have to take maximum slope wherever it is. Suppose there is a fusion of T and U wave. Like here, there is a maximum slope in the T wave, whereas here there is a maximum slope in the second half. So we have to consider the maximum slope and measure at the intersection level. And male with more than 440 millisecond and females with more than 460 millisecond, we consider as a cutoff line for a prolonged QT interval. So if we go into the basics, action potential. So we know that cardiac myocytes are having 4 phases of action potential: phase 0, phase 1, phase 2, phase 3, and phase 4. So phase 0 is for the depolarization, which happens with the sodium channel, with the entry of the sodium into the cardiac myocytes. And repolarization wavefronts will be in the phase 1, phase 2, and phase 3, where the phase 1 is a rapid repolarization, which is happening mainly because of the transient outward current from the potassium ITO channel. And phase 2 is basically a plateau phase, which is maintained by the inward calcium current and outward potassium current. And then the phase 3 happens, which is a rapid repolarization phase, which is happening mainly because of the IKR channel, rapid rectifier channel, potassium channel, and it is an outward potassium current. And then the phase 4. So anything which is happening with the phase 0 or phase 1 or phase 2 or phase 3 can lead to the prolonged QT interval or prolonged basically action potential. So the prolonged QT interval is actually a surrogate measure of the prolonged action potential duration. And what happens most of the time, this prolonged action potential duration, because of any reason, whenever it is happening, it does not happen homogeneously throughout the cardiac myocytes, because the ventricular wall, if we see to endocardium or a mid myocardium or a epicardium, these channels, the density of the channel is not homogeneous, it is heterogeneous. And because of that, there will be inhomogeneous lengthening of the action potential duration. And that results in the transmural dispersion of APD, that known as transmural dispersion of repolarization. We'll discuss in the later slide. So acquired long QTS is by far more prevalent than congenital long QTS. It is characterized by QT prolongation and sometimes torsades de pontis. And majority of the acquired long QTS results of the QT prolonging drugs or electrolyte abnormalities or bradycardia. And the culprit agents, which may include antihistaminics, antibiotics, antidepressants, prokinetics. There are few drugs which are more likely to cause QT prolongation and TDP. There are few drugs which are likely to cause but less common. We'll discuss later on. What is the importance of acquired long QTS? So the importance remains in the two main consequences. One, there is unacceptable risk of sudden death, especially when being medically treated for non-life-threatening condition. And the second implication is that whenever we are developing new drug, and because few patients develop torsades de pontis and long QT as a side effect, and these drugs needs to be withdrawn from the market. So these two are the major consequences of acquired long QTS, which we have to address. So in majority, interaction occurs with the IKR channel. So it's in the phase 3 mainly, and in some with the late sodium current also. In most, QT interval returns to normal after discontinuation of drug or trigger, but in some cases, QT interval remains prolonged once it is prolonged by any trigger. And acquired long QTS may share some genetic background with the congenital long QT syndrome also. Like in long QT syndrome, we have found out almost 16 disease-causing genes, and mostly which encodes cardiac ion channel subunits or associated protein. Genetic breakdown could be important even in the presence of modest QT prolongation, because whenever these cases are associated with appropriate triggers, it may favor life-threatening manifestation of acquired long QT syndrome. Now, if you see the etiology of acquired long QT syndrome, the most common reason is drugs. And the drugs which frequently cause torsades de pointes are one of the antiarrhythmic drugs, especially class 1A and class 3 antiarrhythmic drugs. Class 1A can be quinidine, disopyramide, or procainamide, and class 3 can be ibutilide, dofetilide, and sotalol. These drugs are associated more with the torsades de pointes. And the drugs which are clearly associated but with the low incidence are amiodarone, arsenic trioxide, then antibiotics and other drugs, which we'll see later. And other than drugs, electrolytes abnormality, hypocalcemia, hypokalemia, hypomagnesemia, hypothyroidism, then bradycardia, either because of complete heart block, complete AV block, or sinus node disease, more common with the AV block, or acute myocardial infarction. CNS causes subarachnoid hemorrhage, then starvation or a liquid protein diet. And recently it has been noted that anti-SSA and Rho antibodies can also lead to acquired long QT syndrome because these antibodies are directly interacting with the IKR channel, and because inhibition of that leads to QT prolongation. If you see the drugs, there are a lot of drugs which can cause QT prolongation and finally which can cause torsades de pointes. Anesthetic drugs may be propofol or sevoflurane. Antiarrhythmics we have already seen, amiodarone, class 1A and class C drugs. Antibiotics, azithromycin, clarithromycin, erythromycin. Then amongst the fluoroquinolones, levofloxacin, moxifloxacin. So if you see the middle column there, it shows the incidence in form of percentage, where for some of the drugs, incidence percentage is available. Most of the drug, it is not available. If you see the amiodarone, whenever we give an oral administration, the chances of getting or arrhythmia is 0.7 to 0.8%. And with IV, intravenous administration, it goes almost to 1.5% chance of getting arrhythmias. If you see dofetilide incidence is very high, especially if it is given with the heart failure and reduced ejection fraction, or it is given inappropriately higher dose. If you see the azithromycin, 0.97% of the patients with QT interval of more than 50 milliseconds during azithromycin therapy can, if QT interval is more than 450 and azithro has been added, the chance of getting arrhythmia is almost 0.97%. If the QT is normal, then the chance is less. Then there are a lot of other drugs, antidepressants, antiemetics, antifungal, antimalarial, antipsychotic, especially haloperidol, which is having higher incidence of arrhythmia. Then coronary vasodilator like papaverine, which is not currently much commonly used, illicit drugs like cocaine. So there are a lot of drugs which can cause, especially if we go to antimalarial chloroquine and hydroxychloroquine, because recently during COVID, the hydroxychloroquine associated QT prolongation and arrhythmias were discussed a lot. But actual incidence and prevalence of hydroxychloroquine induced acquired long QT and arrhythmia is still not available. Now, if we go to the genetics, like for congenital long QTS, we all know that there are mainly three types of LQTS, which are common one, where the LQTS 1 and 2 is mainly associated with potassium current, and 3 is associated with sodium current with distinct T-wave morphology and distinct triggers which can lead to the sudden cardiac arrest because of the polymorphic VT. So if you see, there are multiple genes associated with congenital long QTS already identified. Autosomal dominant Romanov having almost 10 types, and autosomal recessive is Jarvell-Lange-Nielsen syndrome. So we are not going to detail into this, but one study which was done for acquired long QTS, where it was compared with the congenital long QTS, like the 957 of congenital long QTS cases, the KCNQ1 was the most common gene, followed by KCNH2, and less common was SCN5A and KCNE1 and E2. But against, there were 51 acquired long QTS. So acquired long QTS cases were having a higher chance of getting like KCNH2 mutation. So KCNH2 mutation was associated more commonly, followed by KCNQ1. And out of these 51 cases, they divided it into a true acquired long QTS and unmasked congenital long QTS. So the true acquired long QTS cases where QT was actually getting normalized after withdrawal of the trigger. So QT was normalized. It was labeled as a true acquired long QTS. There, 64% was having a KCNH2 mutation. So the conclusion is that from the genetics point of view, the QTC, in absence of trigger, is shorter in acquired long QTS compared to the congenital long QTS. But those who don't have congenital long QTS, these cases were having significantly longer QT interval, and 28% of the acquired long QTS subjects have mutations in either congenital long QTS related genes, and the most prevalent mutation was KCNH2 gene. So basically, this acquired long QTS represents at least in part a latent genetic predisposition. They may not have clinical presentation in absence of triggers, but whenever they are exposed to triggers, they are showing QT prolongation, and they may represent a latent genetic predisposition in such cases. So in clinical practice, greater attention should be paid to even mild QT prolongation, because this could represent a signal of potential risk of manifestation of acquired long QTS if they are exposed to appropriate triggers. And some individuals were initially labeled as acquired long QTS are diagnosed as congenital long QTS, mainly the unmasked congenital long QTS, because they were having lack of QT normalization after removal of triggers, and they should be treated as such. So identification of this mutation carrier may prevent may prevent the risk of life-threatening arrhythmias. Now, if you see about the torsades de pontis, mainly the mechanism of torsades de pontis is early after depolarization. So what is torsades de pontis? It is characterized by QRS complex of changing amplitudes, and that appears to twist around the isoelectric line, and which occurs at a rate of around 200 to 250 beats per minute. And TDP is a polymorphic VT associated with QT prolongation, which may be either a congenital long QT or acquired long QT. And the clear incidence of TDP in general population is unknown, but few studies shows that 6% of the cardiac arrest in adult ICU were because of this torsades de pontis. So it is a significant percentage. So what is early after depolarization? So basically it's a triggered activity, and that leads to depolarizing oscillations in the membrane voltages. So how it is happening? So basically, because of QT prolongation, there is prolongation of action potential duration. And because of the prolonged action potential duration, there is increased influx of the calcium through the L-type calcium channel during the cardiac cycle. And this excessive accumulation of calcium leads to spontaneous release of calcium from the sarcoplasmic reticulum. And that leads to increased cytosolic calcium concentration. That leads to the sudden activation of sodium calcium exchanger inward current. And that leads to re-depolarization of sarcolemmal membrane during repolarizing phase. Like you can see here, phase 2, early after depolarization, or phase 3, early after depolarization, there is re-depolarization. And at some extent, it will basically activate the sodium or calcium current, and that leads to the after depolarization. So this early after depolarization basically leads to the arrhythmia. So short sequence, cardiac sequence is seen both acquired and congenital long QTS, and that is one of the arrhythmogenic mechanism. So basically, as we know that repolarization is modulated by multiple channels, but what happens that there is repolarization reserve theory, which tells that if one of the mechanism is abnormal, the QT interval or repolarization is still normal. But if there is another additional perturbation in the mechanism, like either a drug or hypokalemia or hypomagnesemia, what happens that this repolarization reserve will get diminished, and finally it will result into the QT prolongation. So we need actually multiple factors to induce QT prolongation and arrhythmias. So as I already told that the current densities is different in epicardium, mid-myocardium, and endocardium. And because of that, the action potential duration prolongation will be heterogeneous, and that leads to transmural dispersion of repolarization. So what happens finally? Drugs introduction, which inhibits the IKR current, leads to action potential duration prolongation with transmural dispersion of repolarization that leads to early after depolarization. And then it will create a propagated response, and that leads to an extra beat, and this extra beat might create a functional re-entry transmurally, and that leads to development of torsades de pontis. So this is the sequence of event which happens. Now, what are the risk factors which may lead to the torsade? Basically, torsade is often transient, self-limiting, and spontaneously terminating, but it can degenerate into ventricular fibrillation and cause SCD also. So the risk factors are baseline QTC more than 500 or QTC lengthening of more than 60 milliseconds, female, elderly, bradycardia, acute myocardial ischemia, dyselectrolytemia, hypokalemia, hypomagnesemia, or hypocalcemia, heart failure with reduced ejection fraction, concomitant administration of more than or equal to 2 QT prolonging drugs, patient who had already history of drug-induced TDP, or elevated plasma concentration of these drugs, either because of drug-drug interaction or rapid IV administration, or patient who is having reduced clearance of the drug, or patient with who are having genetic predisposition. And the studies have shown that 30% of the acquired long QTs already having a genetic mutations, and so they are predisposed to the torsades de pointes. So these are all the risk factors. When they combine all together, will lead to the torsades de pointes. So like this is one case example of acquired long QTS, 73-year female, bacterial pneumonia, basal QT, we can see it is 396 millisecond. Patient is been given ciprofloxacin, has developed hypokalemia of 2.2. We can see the monitor, it's showing QT prolongation and then torsades de pointes. And when the cardioversion was done, ECG had showed a marked QT prolongation. This is one of the example of acquired long QTS and torsades de pointes. Then what is unmasked congenital long QTS? Here we can see a 52-year-old male, alcohol withdrawal symptoms, and was treated with haloperidol 6 milligram. We can see the basal QT was already mildly prolonged. It was 466 millisecond, and over and above he received a haloperidol. He developed hypokalemia with 2.3, and you can see monitor there is an extensive QT prolongation of 624 millisecond and leads to the torsades de pointes. And when the genetic analysis was done, it was showing KC and H2 mutation. So this is somewhat like unmasked congenital long QTS. There are multiple examples of long QT syndrome associated torsades de pointes. Here, a case of HIV, a patient received a pentamidine, had developed a hypokalemia, and finally leads to the torsades de pointes. Here we can see the feature of torsades de pointes is decrease in the amplitude of the entire QRS complex, but QRS axis is almost same, only the change in the amplitude is there. Whereas here we can see that almost the twisting of the QRS axis, it is all positive here, it is all negative here. So the axis has directly twisted almost 180 degree. So this is also one feature. And then another feature is that different pattern can be seen in the different VT episodes. So if we see the QRS morphology, during different episodes, it may be having different morphology. It is not showing a typical twisting around or such pattern. So these are all different examples. You can see that most of the time they are having either a potassium disorder and they are on some drugs, or they have been administered some drug, which also leads to the QT prolongation and finally leads to the torsades de pointes. Then another example is here hypokalemia and hypomagnesemia. We can see here in ECG there is QT alternance and T wave alternance also. So this T wave alternance has been shown in studies that they are associated with more transmural dispersion of repolarization, and they are more likely to cause complex VT. So they are more likely to experience cardiac events like syncope or cardiac arrest. So T wave alternance or QT alternance is risk factor for development of TDP. Then this is the last example of a 63-year-old female HIV. She was on efavirenz, and efavirenz has led to a QT prolongation with T wave alternance, has developed torsades de pointes, and she needed atrial, a ventricular overdrive pacing, and overdrive pacing has suppressed the QT, suppressed the torsades de pointes. So what are all, these are my last two slides. What are all prophylactic measures which we need to check? So whenever patient is admitted and is on multiple drugs, a cardiac disease, always prepare a drug checklist, that whether he is on any drug which can cause QT prolongation or increase the risk of TDP. Always prepare a drug interaction checklist. Then any patient who is hospitalized and he is on QT prolonging drugs, QT interval should be monitored daily, preferably with a 12-lead ECG, and QTC should be maintained at less than 500 milliseconds. So whenever there is, we have to see whether any concomitant administration of drugs, which can either inhibit metabolism of another QT prolonging drugs or increase the blood level of another QT prolonging drug. So basically drug interaction. So drug interaction should always be watched for. And if patient is having a renal dysfunction or liver dysfunction, the drug doses always should be adjusted according to the clearance or a liver function. because these are the common reasons which can prolong the QT interval in already admitted patients, critically ill patients, ICU patients, and that leads to the torsades de pontis. Then potassium should be kept more than 4 and magnesium should be kept more than 2, which also decreases the chance of getting torsades de pontis. This is my last slide. Like the patient who has already developed torsades de pontis, what should be done? Check the drugs, discontinue the QT prolonging drugs, correct hypokalemia, hypomagnesemia, and hypocalcemia if it is there, and any hemodynamically unstable torsades de pontis should always undergo defibrillation. Synchronized shock may not be possible in such cases because of polymorphic VT, so we have to give a defibrillation. And the patients who are having hemodynamically stable torsades de pontis, we should always give Maxsulf. We usually give 2 gram IV, regardless of the magnesium level. No need to check magnesium. Magnesium is normal, or magnesium is on the lower side. We have to supplement. How the magnesium works? So basically, magnesium will inhibit the calcium channels, and because of that, it will suppress this early after depolarization. So Maxsulf is the key drug here. Then those cases where there is recurrent TDP and there is associated bradycardia, we have to increase the heart rate. Heart rate increase will lead to the reduction in the QT interval, will suppress this early after depolarizations and short and PVCs, and will decrease the chance of getting torsades de pontis. So it can be done either by the isoproterenol or overdrive pacing, but the isoproterenol, we have to be very precautious. Sometimes it may increase the chances of arrhythmias. So it can be given until the overdrive pacing has been performed. Once it is there, we have to stop isoproterenol. Overdrive pacing, maybe atrial overdrive, is always better than the ventricular overdrive because it is more physiological. It will reduce the QT interval more in a more better way. But we have to see that patient is having a normal AV conduction, because if we do atrial overdrive pacing and if the AV conduction is not good, patient is getting paroxysmal AV block, we might get the pauses, and that will again provoke ventricular arrhythmia. So if the patient's AV conduction is not good, it is always good to do ventricular overdrive pacing, but AV node is good, it go for the atrial overdrive pacing. So many times we go for a dual chamber pacing. So I'll show in my case example in the next presentation. Then what is the role of class 1B antiarrhythmic drugs, especially mexilating? So mexilating has been shown to reduce the recurrence of torsades de pontis. It can shorten the QT interval also. Then one of the drug which we recently commonly use, especially for atrial arrhythmias, that is ibutyllite therapy. So people have tried like pre-treatment with high dose Maxsulf, almost 4 to 5 gram, and that reduces the risk of torsades de pontis associated with ibutyllite therapy. So in conclusion, it is always better to take prophylactic measures, especially in admitted patients, to reduce the chance of acquired long QT and torsades de pontis. Thank you.
Thank you, Hiren. That was an excellent presentation. You covered everything regarding acquired long QT and its management. Dr. Suchit, I'd like to invite you, and everybody else on the panel. Welcome, Dr. Yash. Happy Teachers' Day. So let's have a good discussion.
Yeah. So Hiren, that's a magnificent talk. Just one or two things that whenever you are treating a long QT syndrome, means magnesium you want to give over what time, and do you want to continue a drip? Can you make it clear in that?
So most of the time what we do, like the studies have, am I audible?
Yes.
Yeah.
Yeah, so the studies, like especially for the ibutyllite and all, people have given almost 4 gram Maxsulf bolus over 1 hour. They give almost over 30 minutes to 1 hour, and then they give, ibutyllite. So in other cases, rest of the cases where we suspect acquired long QT or long QT and torsades de pontis, what we usually do, we give 2 gram Maxsulf for 10 to 15 minutes. And then most of the time we give bolus therapies in form of either 1 to 2 gram 8 hourly. And we try to keep the, we should be watch for magnesium level also. We try to keep the magnesium level at around 2.4. So that is a higher upper normal. Because we have to watch for the magnesium toxicity also, which leads to like respiratory depression, areflexia. So with the monitoring of magnesium level, we give usually 1 to 2 gram 3 times in a day as a bolus.
So that is also very important because some people may have some, one of the causes of acquired long QT can be some magnesium deficiency secondary to some magnesium losing. So that is also very important, maybe Gittelman or something, which whenever you are giving magnesium, just see that the magnesium level is rising or not. Sometimes even if you give magnesium, it may not be adequate. And secondly, if you have an acute torsade, you can give a 2 gram over 4-5 minutes also initially, and you can start a drip after that. So that is important.
Correct.
Then one question for you, when is amiodarone pro-arrhythmic, in which circumstances? If you can highlight that. And secondly, which antiarrhythmic drugs do you start in hospital versus on OPD basis?
So I like to answer second question first. So which drug I would like to start whenever I face acquired long QT and polymorphic arrhythmia? So it is always better to give injectable drugs initially because oral drugs might take some time to build the drug level. So most of the time we start with the lidocaine, so Xylocard. So we give Xylocard, bolus and infusion to suppress these arrhythmias. And with the Xylocard, we start the mexilatin also. And once the 24 hours or 48 hours of mexilating is over, by the time we'll taper off the Xylocard and switch over to oral mexilating therapy in admitted patient also. And in OPD basis, always, mexilating is the drug which we use commonly. Then the second question, I forgot, what was that?
Intravenous amiodarone is
intravenous amiodarone, sir. So whenever we give a class 3 drugs, either amiodarone or sotalol, there is somewhat differential effect on action potential duration. Like amiodarone more of a cause phase 2 prolongation, and sotalol and all cause phase 3 prolongation. So what happens whenever there is phase 3 prolongation of action potential, it leads to somewhat like triangulated appearance of action potential. And amiodarone will lead to phase 2 prolongation, which leads to more of a box type action potential duration prolongation. So studies have shown that the box type action potential duration prolongation is associated with less associated with arrhythmias than the triangulated action potential prolongation, which is with the sotalol mainly. So Cordarone overall has shown to have, it will not cause that much transmural dispersion of repolarization, though it causes QT prolongation, but the chance of getting torsades de pointis is very less. But yeah, maybe acute ischemia is the one where it might still cause the torsades de pointis. That's what I feel. So that's why
if I may step in here, actually, the way we say it is amiodarone causes more homogeneous prolongation, and that's why the dispersion is less and the chances of re-entry and arrhythmias is less. Whereas the other drugs causes, there is more differential prolongation of the repolarization that predisposes to arrhythmias more. I think what Dr. Ashish was asking was when you're starting antiarrhythmic drugs, which drugs would you be careful while starting in outpatient? Whether you would rather admit the patient for say atrial fibrillation or anything. You're starting antiarrhythmic drugs. Would you rather admit the patient and give the drugs, or how do you go about it?
So that plecanide is one. Plecanide is one such drug. Dofetilide is also that, but dofetilide is not available in India. So we are not. But otherwise, dofetilide is high likely to cause QT prolongation and torsades de pointis. Plecanide can also, but plecanide is found to be less common to induce all these problems. So dofetilide definitely, because we are not having a practical exposure for using dofetilide, but I'm not sure in West they may be monitoring QT and all during initial dofetilide therapy, like initial 24 to 48 hours. But most of the time, if you see the flecainide, we start on OPD base with maybe on one monitoring of ECG. We don't routinely monitor the ECG on flecainide, especially there is structurally normal heart. Structurally abnormal heart class 1C should be used very precautiously. It may actually increase the mortality risk.
So Ajay, I have a question. Things are elderly patient and LV dysfunction. If these two issues are there, then we have to be very careful because this is where the problems will occur. I think Dr. Chandrasekhar was asking.
Actually, just one comment. Regarding the terminology, the polymorphic ventricular tachycardia or the torsades de pointis, usually it is said that polymorphic ventricular tachycardia, you should say in those patients with the normal QT interval, whereas especially more commonly it can happen in patients during acute myocardial ischemia. And the torsady point is we should say only in those with underlying QT prolongation. And one more comment is, I think for the fellows, it's actually the giving isopril for suppressing the ventricular tachycardia. That is the torsady point is this, what we call it as a therapeutic paradox.
So,
Yash, you must be squirming in your seat because they are not saying torsa de poing. So let me say that first.
No, I know it hurts. It hurts. But I had a couple of points. So as I understand, Hiren, you beautifully translated cell to bedside as much as is, lot of sometimes we need to know the basics, and it does help. And this is long QT, certainly one where you try to correlate the action potential with the clinical presentation. As I understood correctly, the longest QT in the absence of torsade in a resting state, the longest QT would be congenital long QT, obviously. Then it would be the acquired long QT, and then it would be the normal people, correct? So the acquired long QT would still have a QT which is longer than normal. But for an individual patient, you can't make out on that, but maybe as a population cohort, one can make out. My second question to you was that the sotalol, and that is what people need to also understand, sotalol has reverse rate dependence, and that is one of the nasty things about sotalol. Amiodarone works better at higher heart rates, which is where you want it to act. Sotalol works more at lower heart rates, which is where you don't want it to act. And therefore, sotalol with bradycardia is a nasty combination. So apart from the fact of non-homogeneous dispersion of repolarization, bradycardia is a really bad situation to have with sotalol. That's what people should realize in clinical practice. Now, my question to you was you showed nicely the early and the delayed after repolarizations. Clinically, is there any way to make out whether it may be academic, but clinically, can you make out whether a torsade is because of EAD or DAD? And apart from digitalis, are there any other causes of DADs that are clinically relevant?
Other than digoxin.
Because that's the only one I remember as a cause of DADs.
Yeah, correct, sir.
Maybe certain
Actually, Dr. Yash, aconitin poisoning, no? Aconitin poisoning.
Oleander.
Aconitin poisoning.
Or oleander poisoning.
Oleander.
It may be toxic.
Yash, I have a basic question. Do all patients with acquired QT have a genetic basis? That means somebody with a potassium of 2.3 doesn't develop anything, and somebody with 3 develops a torsade.
I think that's a good question.
Are we supposed to investigate in acquired QT?
Hiren has covered that. Hiren, can you summarize that? It's a very important message that how many of the acquired long QT really have a genetic basis, and whom should you clinically investigate?
Yes, sir. So those, the studies have shown that almost 28 to 30% of the acquired long QTS patients have been found to have genetic predisposition. The genes are same like congenital long QTS, where the more common was KC and H2 gene. So, still we don't have clear-cut recommendations on like which patients of acquired long QTS should get genetic testing. But that study have concluded that patients who are already having acquired, a patient has developed acquired long QTS and associated torsades de pointes arrhythmias. So that patient should at least get a genetic evaluation, and so that if we found out some genes, then accordingly, in the future, we can reduce the chance of getting future events. But otherwise, there are no clear-cut guidelines that which patient should undergo genetic analysis for acquired long QTS. Yes, those who are unmasked congenital long QTS, like those patients who have developed long QT after some trigger and which is not normalizing after removal of the triggers, that unmasked patient should always go for genetic analysis, where we might find out genetic mutations, and that should be, treated per se.
And Yash, one important point is sotalol. Sotalol anyway causes bradycardia. So what is the rate where you think I would stop or not increase the dose of sotalol? Is there any guideline for that?
So sotalol, actually, one must remember the doses that we use, and at least I use 40 milligram BD. Is
Minimal.
People will say it's typically only a beta blocker. It's not a class 3 drug, but I tend to disagree. Sometimes with 40 BD, we find much more bradycardia than an ordinary beta blocker, and we find QT prolongation also with a lower doses than in the Western population. So I would say any bradycardia which is associated with QT prolongation, I would be especially worried with sotalol, to answer your question. And if the bradycardia is mild and picking up with exercise and QT is okay, I would not be so worried. But one will have to take it on a case-to-case basis. One will have to look for other risk factors for torsad, which Hiren has nicely elucidated. For example, in female gender who has got LV dysfunction and is on a diuretic and sotalol, I would certainly be concerned. Yeah.
One more important set of drugs which causes prolonged QT are the anti-tuberculous drugs which are used for multi-drug resistant tuberculosis. Those patients are many times admitted and the QT is monitored because they tend to give torsades quite often. Okay.
Dr. Yash, in the sotalol, no, if the D isomer only, the QT prolongation is more common when compared to the L isomer. What is your view on that? Because remember that SWOT trial they conducted, because they found out that because of the D isomer of sotalol which was used in the trial, they reported high incidence of sudden cardiac death.
Dr. Yash, we used to talk a lot about this 20 years ago and 15 years ago, but lately we hardly talk about D-sotalol or L-sotalol. That is not relevant anymore, I feel. What are your views?
Yes, I agree. It's a thing of only of historical thing. It's all racemic, standard sotalol. There is a question, and this often comes, in the chat I saw about the beta blockers in long QT, and sometimes we use isoprenaline. So Hiren, can you please clarify in an acute situation, when will you use beta blockers and when will you use isoprenaline?
I think that will come out in the case also, isn't it, Hiren?
Yeah, there will be some discussion regarding that in the case also.
Okay.
But and I otherwise also, like in acquired long QTS, beta blocker has not been used. I've gone through all these studies and the case examples. Beta blocker was not used for any acquired long QTS. So moreover, they want.
I think we can move, Ajay.
Yeah. I think there are a couple of more questions, but I'm sure the case is also based a bit on this, and we'll discuss further. Hiren, can you move on to the case?
Yeah, sure. So I'm just going to present. Am I audible?
Yes, go ahead.
Yeah. So he's a 55-year-old male with diabetes mellitus. He had evolved interval ST elevation MI. He came here to our hospital late. He was having severe LV dysfunction with EF of 25%, mild MR, and mild pulmonary hypertension. He was in heart failure. He was in sinus rhythm, but he had a polymorphic VT, which degenerated into VF, which was deciverted, Codaron was administered, and then he was shifted to our hospital for further management. He was in LVF and class 4 NIHA class. So the ECG, which was done outside, was showing sinus rhythm with Q wave and ST elevation, J point elevation in the anterior chest slits that were showing, features of evolved interval MI. And there was a strip attached in his file where we could see that patient was having almost like a ventricular flutter or something like that. And then that was degenerating into ventricular fibrillation, and that was deciverted. So, we know that in ischemia, patients may develop primary arrhythmias, and they are mainly because of the ischemia itself. So in such cases, we have to stabilize the heart failure, and as early as we have to go for revascularization and alleviation of this ischemia. So as a part 1 of this case, angiography was done, and that was showing LAD ostial total occlusion. RCA was okay, and patient underwent angioplasty, and reflow. Flow was achieved again. So patient was better, LVF improved, but second day patient again started polymorphic VT, which was degenerating into VF, and post PCI second day QTC was nearly 470 millisecond. He had recurrent polymorphic VT degenerating into VF, resuscitated, and he had almost 10 to 15 episodes of such cardiac arrest and revived with almost 20 to 25 DC shocks. As we discussed, we started him on injectable Xylocard. He was on Cordaron, which we reduced a little bit, and we uptitrated the Xylocard. Simultaneously, we started with the oral mexilating also, beta blockers also, and Mexelf as recommended, it was also given. So he was on multiple antiarrhythmic drugs, Mexelf therapy, beta blocker, but he was still having recurrent polymorphic VT. So what we planned him because he is already on the multiple drugs, and we noticed on the monitor that there were few PVCs which was inducing polymorphic VT. So we planned for overdrive pacing, and we put a dual chamber temporary pacemaker, one to the RV and RA. We paced the atria at a faster heart rate, and there was one-to-one good AV conduction. So we thought that, okay, let us do atrial overdrive pacing. So we did atrial overdrive pacing, and after atrial overdrive pacing at around 100 beats per minute, the QTC came around 440 millisecond. It suppressed that PVCs which were coming, and that leads to suppression of polymorphic VT and VF. But once we reduce the atrial overdrive pacing rate to 90 or less than 90, again that PVCs were coming, degenerating into, inducing the polymorphic VT, which was degenerating into ventricular fibrillation. So what we did, so we continued all the treatment, and we just attached a halter to see what is happening and what is inducing the arrhythmias. So patient was attached with the halter to look for these triggers of polymorphic VT or VF, which was happening almost 4 days after primary, after MI. So it was going beyond 48 hours of initial MI duration. So what was happening? So in halter, we could record multiple episodes of VT and VF. And the event which was happening was a short coupled PVC that was leading to R1T phenomenon, inducing polymorphic VT, and which was degenerating into ventricular fibrillation, which was needing a multiple shocks. So when we analyzed the first QRS morphology, which was inducing all these things, so there were multiple three morphologies of PVCs which were coming, falling on T wave, and they were coming from fascicles. So they were fascicular PVCs. They were coming from anterior fascicle, posterior fascicle, and one was likely looking like coming from LV apical or a distal end of the His-Purkinje system. So we noticed that these are the PVCs coming from the conduction system, and that were inducing these arrhythmias. And once we reduced the atrial overdrive pacing at less than 90, they were coming again and again. So we had to plan something else for this patient. So what we did, we took the patient for 3D carto mapping, and we tried. Actually, what was happening that during mapping also there were multiple morphology, like 3 morphologies of PVCs were coming. We tried to map independently all the 3 PVCs, and we ablated in the region of anterofascicle into the posterior fascicle regions, and we could induce a monomorphic VT also, which is almost very fast, like a flutter at 240 bits per minute, which we cardioverted immediately. We given a short burns of ablation. We did somewhat limited substrate modification during the ablation because patient was already on multiple inotropes in heart failure. We finished this procedure in just 45 minutes. So with the minimal cath lab time, we tried to ablate the fascicular PVCs. Luckily, after ablation, patient was arrhythmia free. Arrhythmias got settled, the PVCs got settled, and patient was observed for next 50 days. During this period, he was kept on atrial overdrive pacing at around 70 to 80 beats per minute. We removed Xylocard. We keep on mexilating and Cordaron, and luckily patient was arrhythmia free for next 5 days. And then finally, we implanted him with the dual chamber ICD because we are still needing somewhat Atrial overdrive at around 80 beats per minute. So we put a dual chamber ICD on the 6th day, and then we kept atrial overdrive pacing with a dominantly atrial pacing by prolonging the AV delay at around 80 beats per minute. And on discharge, he was in a stable clinical condition on amiodarone and maxillating, and obviously anti-heart failure line of management. He was not having any shocks after ICD implantation during the admission. Then he came for a follow-up, and last follow-up he came, he was almost 6 months down the line. He was almost stable, NIHA class 2 with ejection fraction was around 30%. He was kept on low dose amiodarone. Maxillating was tapered off. He is on optimal anti-heart failure line of management, and there were no ICD shocks at a 6 month down the line. So that's how this case was managed. We had almost example of all the types of management which we ideally do for this polymorphic VT. So it was like a combined acute myocardial ischemia, cordaron, short couple PVCs, and everything was inducing polymorphic VT, multiple episodes, managed medically by overdrive pacing, but needed trigger ablation also, and no arrhythmias, and then ICD was implanted for
So
primary.
Hiren, maybe we can direct the discussion over treating the VT storm beyond drugs. There are many experts on board.
Yeah,
Yeah.
Dr. Suchit and Dr. Anup, you'd like to.
Yeah, wonderful case, Hiren, very well managed. Couple of questions from my side. Like, you said there were multiple forms of PVCs and you were quite happy with the atrial overdrive pacing. So did you consider, like, the reverse way, like if you are happy with the atrial pacing, putting a ICD dual chamber, keep it at a higher rate of maybe 100 beat per minute, let it cool down the PVC, and probably, your VT storm would have settled down. Because the thing is, like, day 5 NT-oval MI, large MI, multiple forms of PVC, and doing a substrate mapping, we don't know what is the endpoint, like, where you want to stop. And suppose you have got multiple PVCs, how many PVC are going to really target to ablate? So this is what is my comment and question to you.
Yeah. So I agree, sir, actually. I mean, when we took him for CAR2, we were not sure at what point we'll end the procedure because patient was on already multiple inotropes. But because he was almost given 20-25 shocks, and once we reduce sometimes it was happening at 100 also. It's not like always, but whenever we reduce it to less than 90, the episodes were getting more frequent, and at 100 episodes were almost less. So we waited for almost 2 to 3 days after temporary pacemaker, but that was still happening. So as a bailout, we thought that let us try to, try to ablate the Purkinje PVCs. If we are able to do it successfully, we might help out the patient. So we took the high risk concern. Patients' relatives were also willing that, okay, let us try, because to do ICD when still patient is in VT storm, I was not comfortable. So I want at least 5 days to 7 days, no arrhythmias, then I will go for ICD implantation. That's why ICD I kept as a second option. And first I thought, let us do the ablation.
Ajay,
So if I may just step in here.
Yeah, please. Yeah, sure.
In this type of scenario, we do it both ways, and we've done it multiple ways this way. In some patients where we think we can suppress the arrhythmia storm with atrial pacing, we've put in the ICD, and 50% of the patients would settle down and would not have a problem later, and we can manage with medications. Other 50% after ICDs, they're still getting arrhythmias, and then the device delivers shocks. And it becomes traumatic not only for the patient, but the family and everybody else who's managing the patient. And in this particular case, the episodes were so frequent, and we could see there were various triggers which were starting the arrhythmias. We thought it would be a little difficult to keep pacing the patient at 100 with LV dysfunction, and the patient would go into failure. It would be a bigger problem to manage. So in this case, I think it was a decision taken to ablate first and then take a call after that.
Again, one question.
Sympatholysis, sympatholysis in these settings.
Oh yes, we do it all the time. In fact, these kind of patients, that is something else. We do stellate ganglion block and all. That is part and parcel of the procedure.
Even sedation by itself, ventilation is the first step.
So sedation and
Yeah, means one of the questions you have already asked, I was also asking that why not was stellate ganglion percutaneous block and just see that how the response to the VT is there, and then decide on further planning. One of the issue in ablating in a patient who is on multiple inotropes is that you have to, if you want to map, you have to get the trigger, then you have to allow multiple episodes of VF and shocks and all these things. So I was not clear that how did you get the signal, maybe the earliest point, and maybe if you have a maybe Purkinje signal which is triggering the thing. So for that you have to wait for multiple episodes and multiple shocks in an inotrope. This patient may not be this thing without a mechanical support. How did you manage that, Hiren?
So yeah, it's a good question how we manage. But basically, what was happening when we took him for 3D mapping, we put him on ventilator and we ablated. So he was already sedated. So what was happening that during mapping, multiple PVCs were coming, yes. Torsade was coming, yes, but they were all ill-sustained torsade. We had to cardiovert only twice during the CARTO. So we were lucky that, yeah, sustained episodes were not happening on ventilator. So yeah, but random PVCs which were not inducing torsade were also there. So we tried to map. In fact, we finished it in 45 minutes. It was punctured to come out. So we did it very rapidly. I mean, we may not have done very meticulous mapping of PVCs and ablated. So we were looking at the EGMs during the PVC. Our ablation catheter was showing very early. We were ablating that. So it was not possible to do that proper comprehensive mapping and substrate modification. Substrate modification, in fact, it was just ablated at random few places where we got a very late EGM. So substrate modification was actually not performed in this case very well. It was mainly trigger ablation only. And that was also not possible very meticulously. I told the patient relative that, see, we don't have time. We have maybe maximum 45 minutes. We'll try to do whatever we are able to do and we'll come out. And then we'll see what results we are getting. So it was just a bailed out ablation for him.
So just last comment before we change. In these VT storm and critically ill patients, my aim is always in and out in 1 hour. Get the ablation done, settle the patient down, and get the patient out. So in fact, we've done with rapid VT and only alternate beat producing blood pressure and a BP of 60 or 70. I've done ablation. So all sorts of crazy things. We'll just move on to the sorry.
Dr. Ajay, just one comment. You know, we see so many patients with the atrial MI going for angioplasty. After angioplasty, why some patients develop this type of VT storm? Because we know the Purkinje fibers are resistant to ischemia, and that's why maybe at the border of the infarcted tissue and the Purkinje system, I think they trigger the arrhythmia and then trigger the VT, polymorphic VT and things like that. Why some patients alone develop this? Is there any way to find out, or what is the reason for that?
I don't know.
Because so many patients who are doing angioplasty, they go home happily, but only some patients get into this problem. I think I also had a few patients really this, troublesome and very frightening to see.
I think it is probably not having a infarct which is completely destroying the myocardium. Probably some fibers here are surviving, some fibers there are surviving.
Surviving, and we know that Purkinje fibers are resistant to ischemia. So usually that's why it is coming from the Purkinje system, that fascicles.
Sure. So I'll move on to the next segment. And
thank you.
Thanks, Dr. Chandrasekhar. And I'll just move on to the next segment. I'll try to cover a few cases quickly. We had a run of atrial arrhythmias like everybody else in this forum during COVID, and a spectrum of arrhythmias in COVID in the atrial supraventricular arrhythmia, sinus bradycardia, atrial fibrillation, something like tachybrady syndrome. We also have recrudescence of quiescent arrhythmias, which the patient had been having in the past and was doing well, and then suddenly they started coming again. Ectopic atrial tachycardias were particularly common. Atrial flutter, and obviously ventricular arrhythmias is a completely different story. We had a lot of those. So just to give a perspective, in the COVID era, what we faced was, of all non-AF atrial arrhythmias, approximately 90% would be managed by observation or medications in the COVID. 10% may need some kind of intervention or procedure. Pre-COVID atrial tachycardias would represent just around 2 to 5% of all EP ablations that we were doing. but in the past 18 months, they found approximately 10% of all EP ablation. So there was a disproportionately higher number of atrial tachycardias, and they were particularly unusual. So just giving an example, 65-year-old gentleman, recurrent palpitations past 1 month, treated for COVID 3 months ago. And this was the arrhythmia which was recorded. There's a story behind this, and I'll just talk about it. But this is a narrow complex tachycardia, and you see some P waves before the QRS. The P waves appear to be positive in the inferior leads, and they may be biphasic in lead V1. Here it terminates, and during sinus rhythm, the patient has bifid P wave. In fact, the patient has had a ASD device closure in 2003 and did not have any problems after that. Had undergone an angioplasty in 2016, but good LV function. So this patient had multiple episodes. We took him in the lab. There is 2:1 rhythm going on here, atrial tachycardia, 2:1 conduction going on. And look at the size of the device. This is a 40 millimeter size device. I remarked that the P wave seemed to be positive in the inferior leads, but the focus was in the inferior end of the ASD device. The coronary sinus ostium was